Now, what about the more difficult case? Okay, that's the quick wean. What about the far more difficult case, the people who have been on, and what are those cases? What are the ones where people, COPD patients, patients with existing lung disease, would make it a challenge to wean or might require a long-term weaning? What else? How about patients who have been on the ventilator over 5 days? Have you ever been off your feet for several days because of the flu? Okay. And once you got back on your feet again and started walking, how did your legs feel? Wobbly? You had your sea legs? Well, respiratory muscles do the same thing. You don't use the respiratory muscles for an extended period of time, and they quickly start to atrophy and lose function. So one of the things, like patients who have been on assist modes of ventilation for a long period of time. You know, patients who are going to be on the ventilator long term, I think it's a good idea to start as soon as possible, even if you don't plan to get them off the ventilator today. As soon as possible, get that patient involved in their own respiration. Do some muscular work, either CPAP trials or SIMV with pressure support, but get the patient involved, because muscle atrophy, particularly in a patient who already has COPD, might make it quite a challenge to get that patient off the ventilator. So how long you've been on the ventilator, what mode of the ventilator you're on, pre-existing lung disease, things like that. One of the big factors is ventilator-associated pneumonia that keep our patient on the ventilator for an extended period of time. And the statistics are that people who've been on the ventilator over 72 hours or 96 hours are at high risk for ventilator-associated pneumonia, and therefore that's going to delay them possibly another week and make it even more challenging to get them off the ventilator. So the point I'm trying to make is the longer you're on the ventilator, the longer it's going to take to get you off the ventilator, unless you have an extraordinarily healthy 20-year-old who went into ARDS, and you know, they might wean quicker than the 80-year-old COPDer. So what's the approach? And this is where it gets difficult, because there's no right or wrong answer. There's a lot of literature out there, and everybody has their own way to do it. The use of SIMV is very popular in long term, turning the SIMV down, weaning the SIMV to CPAP, and then using, once the patient is in CPAP and has an intact drive to breathe, and use pressure support. Now, how do we decide how much pressure support to use? Well, this is a hard thing to know, because you're balancing the patient's muscular effort against the ventilator doing the work. So it's a balance of that. At one level of CPAP, at a low level, the patient might be doing a significant amount of muscular effort. It might be enough muscular effort to cause them to fail. And then a higher level of CPAP, you might say the ventilator is doing too much work and the patient's not really working their muscles out. So how do you find that right level? And this is a real art. There are better tools now. In fact, I heard some encouraging things about the use of the NICO monitor, a monitor that gives you CO2 production to help you determine conditioning versus deconditioning. Because certainly if one of the ways we attempt to wean patients in acute care hospitals that's a failure is we go straight to CPAP, and then we let them go till they fail. Well, so what's evidence of failure when you're on CPAP? Let me make a list of them. What's evidence of failure? So I put you on CPAP. You're a COPD, or you've been on the vent for 2 weeks now, and I think your condition's starting to resolve, and I want to try to wean you. So I put you over on CPAP. How about a frequency of greater than 35? Absolute failure. Okay. How about a tidal volume less than 300 ml, perhaps, depending on the size of the person. Yeah, PaO2 or FiO2 ratio. There's another good one. There's some criteria to judge. Also, the patient's vital signs. I mean, you know, what happens when patients start to fatigue? Their heart rate increases, their blood pressure might go up. So their vital signs. So it's nice to have a baseline of data before you put the patient on CPAP. so that you have something to measure it from. So let's say this patient went for 2 hours and eventually failed because they were breathing 40 breaths a minute, shallow, their heart rate is way up, they're just sweating bullets, you know. The question is, how much harm did we do that patient during that period? Is it possible that we decondition that patient? I mean, we know, you ever work out beyond what your muscles can do, what do? Huh? They get sore, they produce lactic acid, and it could be a setback. Well, we can easily do this to this patient too. So how do I know where conditioning is? Where did I know where to stop? So this approach of pushing the patient to failure and then doing that every day and then throwing up our hands and saying, well, they can't be weaned. Every day we put them on CPAP, they fail. And so they stay on the vent for weeks until a long-term acute care facility will take them. And then at long-term acute care, they take a little different approach. They use a little more, use a few more tools to figure out where is conditioning and where is deconditioning. How far do you go? Some of the data suggests that you shouldn't maybe wean people for over 2 hours, but I can't say that because everybody's different. I mean, some people might decondition after 30 minutes. They're a little more, they're slower with their weaning. They don't push the patient to the point of failure every day. They push the patient to the point they think they're conditioning him, and they take it slowly. And then using that approach, they're able to get the patient off in a couple of weeks by taking it slow and not deconditioning them. So that's the problem in acute care hospitals, is we're not real good, unfortunately, at weaning these really hard to wean cases. I think the thing is trying to figure out what that patient can do. There's got to be some data out there. I'd have to look it up.
It says not, in our book, it says not more than 2 hours.
Not more than 2 hours, yeah. And is that, you reference that to Egan? Yeah. So this whole idea of just putting a patient on CPAP until they fail is probably not a good idea, and that's what we do now, unfortunately. You know, and if they made it 2 hours, go to 3, 4, 5, 6, 12 hours, you know, and finally. Now I can understand our reluctance to extubate the patients because the failure rate, and I think we might consider a failure as people who had to be re-intubated after 48 hours. It's high with people like this. So, but what are some of the things we can do to help our weaning process? Well, things to prevent ventilator-associated pneumonia. That's going to definitely be a setback, VAP. It happens so frequently. Good nutrition is important. You know, what kind of nutrition do our patients get? Are tolerating tube feeding? If not, are they getting TPN? There's a lot of data that suggests that poor nutrition makes it very difficult to wean people. Yeah. Oh yeah, that's a good one. I didn't think of that, but managing their anxiety and depression.